Welcome. Good evening. Welcome to tonight's webinar, Updates from THT, a roundtable discussion with Dr. Phil Adamson. I'm Kathy Clark-Danby, and on behalf of the CBRX Medical Education Team, we thank you for taking the time to join us tonight for what will be a fantastic discussion. A few things to keep in mind before we get started. As we get into tonight's discussion, please utilize the Q&A function on the webinar, and we will bring as many questions as we can to the attention of our faculty. Due to time limitations, we may not get to all questions tonight, but we will be happy to follow up with you afterwards. There are also several educational resources available in the Resources tab on your screen. And with that, I'm going to bring on our host, Dr. Phil Adamson. Dr. Phil Adamson is a world-renowned advanced heart failure and transplant cardiologist, and he's also our CBRX Chief Medical Officer. Welcome, Dr. Adamson.
Well, thank you, Kathy, and welcome to everyone. Good evening. And I'm really would like to add my gratitude from CBRX for your attending this webinar. I'm excited. I think we can have a really cool evening that is going to be punctuated by interaction. So we really ask you to ask your questions in the chat, the Q&A chat area, and we'll get to as many as we can. Our webinar tonight will highlight the newest clinical findings on baroreceptor activation therapy using the Barostim device. So this innovative therapy delivers electrical stimulation to the carotid baroreceptor nerves in individuals with heart failure, aiming to improve quality of life, enhance functional status, and stabilize disease progression. And all these benefits are supported by reductions in clinical trials in heart failure biomarkers such as NT-proBNP. The Barostim device was approved by the US FDA for use in patients with heart failure and reduced ejection fraction with EFs less than 35% who remain with New York Heart Association Class 2 or 3 symptoms despite either a previous hospitalization for heart failure within the last 12 months or an NT-proBNP level below 1600. This approval applies to patients already receiving maximally tolerated guideline-directed medical and device therapies. So let me introduce our presenters, a wonderful group of folks, great physicians and scientists. Dr. Jacob Abraham, the head of the Advanced Heart Failure Program at Providence Heart Institute in Portland, Oregon. Dr. Patrick McCann, who runs the Heart Failure Program at Prisma Health in Columbia, South Carolina. And Dr. Dmitry Yarnov, who leads the Advanced Heart Failure Program at Baptist Memorial Hospital in Memphis. Our presentations will detail Barostim's effects on cardiac filling pressures and exercise tolerance, arrhythmia burden, and volume management, as well as explore how these sort of basic pathophysiologic observations may actually correlate to the risk of future healthcare utilization, such as hospitalization or ER visits. Each presentation will be followed by a brief discussion period with an extensive panel discussion at the end of our webinar. The data sets presented were recently shared at the THT meeting in Boston, and the hospitalization data were simultaneously published in the Journal of Cardiac Failure. And as Kathy mentioned, we really do encourage you to submit questions at any time, and we'll get to as many as we can. So let's start with Dr. Yarnov's observations on Barostim's impact on cardiac filling pressures and exercise capacity. Dimitri?
Sure. Thank you, Phil. Thank you, Kathy. Glad to be here with you. A lot of us were there at THT. We're very excited, certainly in general, and there was a lot of excitement about the new data about Barostim. So, Kathy, I'm trying to figure out how do I see the slides. Anyways, this gallery and go on the stage. Give me just 1 second. Sorry, got it. All right, so this is a study that is a single center looking at all comers with heart failure with reduced ejection fraction. Those patients who could exercise with cardiopulmonary exercise testing, which is all of us routinely perform in advanced heart failure institutions, were included in the study. And CPX was repeated 3 months after max titration of Barostim. And we can talk later what is the max titration of Barostim for us was at that point. So data that was compared was pre and post Barostim cardiopulmonary exercise testing, namely cardiopulmonary exercise time, peak VO2 or peak oxygen consumption, also minute ventilation carbon dioxide or VCO2 slope. If you can go to the next slide. So this was baseline characteristics, which if you remember BEAT-HF data, those patients were a little bit younger with regards to LVEF were a little bit lower, about 23%, which again calls for my bias. This is an advanced heart failure space. A lot of comorbidities, including diabetes, atrial fibrillation, coronary artery disease, some CKD, and NT-proBNP, which was within the indication, but lower than a lot of us would expect with EF of 23%. But again, I'll only partially joke about it, that even seen advanced heart failure cardiology, advanced heart failure center can reduce NT-proBNP in its own. So this is a pre-implant on a very optimized patients who continue to experience symptoms despite guideline-directed medical therapy. So if you go to the next slide, please. So there was a total of 20 Barostim implants and a consecutive 20 patients who were able to be included in the analysis. Mean age was 55 plus minus 13 years. Again, 35% females and a large African-American population that reflects geography where we practice. All patients, a majority of the patients were in YHA class 3, 90%, 10% of those patients were class 2, but they all had to have in YHA class 3 symptoms to follow the label. And the mean injection fraction, as I mentioned before, was 23%. So exercise time increased with mean exercise time at baseline almost 5 minutes, 4.9, went up to 6 minutes, 3 months post max titration of Barostim. Peak VO2 increased from 12.2 on average up to 13.9. And we did not observe any change in VCO2 slope when we compared the two groups. If you can go to the next slide, I'll show you all the patients plotted on 3 graphs. This is an exercise time. There was several patients that did not respond, very few. Only 2 of them that actually stayed the same, and 1 had a slight downtrend. That patient actually transitioned to LVAD. Soon after, peak VO2 went up, and you can see the same response here. Majority of the patient improved. There was only 2 patients who declined, and that was a long decline in their exercise time. And then you can see show the plot for VCO2 slope. Again, there was no difference in those compared pre and post Barostim implant with regards to VCO2 slope. And in the summary of those findings, Barostim significantly improved cardiopulmonary exercise time and peak VO2 in those patients with HFrEF, EF less than 35%, and NT-proBNP less than 15, who could exercise in cardiopulmonary exercise testing pre and post. So with that, I'll open the discussion. Go back to you.
Thank you, Dimitri. Patrick, what are your thoughts on the exercise time and what Dimitri saw in his patient population?
Yeah, I think it's a very elegant evaluation of the effects of baroreceptor activation therapy. For us, it was very nice to see this because it was a validation of what we've been seeing in our patients since the start of our program. We see people being able to do more endurance, certainly in their activities, and so I think this is the like I said, very elegant evaluation of the effects that we're seeing in clinical experience with this therapy.
So Jacob, we saw in BEAT-HF where the endpoint of functional assessment was a 6-minute hall walk test. So what are your thoughts about correlations of formal exercise testing versus a 6-minute hall walk test, and how does that relate possibly to explaining those clinical trial results?
First of all, I would point out.
Yep, you're good.
I'm good. I would first of all point out it's important for us to remember that increases in exercise time and endurance are actually not frequently seen with medical therapy. So when we think about guideline-directed medical therapy and its benefits, certainly in terms of mortality and reducing heart failure hospitalizations, that has not, in fact, translated into a significant improvement in exercise for many of our patients. And so, this is really encouraging data because it shows that in patients who are already on optimal medical therapy under Dr. Uranov's very capable hands with those low NT-proBNPs, they're still able to enjoy a significant improvement in their exercise tolerance and their peak VO2. And while it may seem that, there was only a 1.7 minute increase in their exercise time, when you're exercising at peak capacity, that's actually quite significant, which is different from just walking in a hall walk at one's own pace. So I think we need to recognize that that actually represents a fairly significant increase in exercise tolerance. And I said 1.7 was the increase in their peak VO2, and it was about 1 minute in their exercise time. So that 1.7 increase in the peak VO2 is quite significant, actually, especially relative to other therapies like CRT.
Yeah, makes sense. And Dimitri, did you see that translate to patients coming back and saying, hey, my clinical situation's better, I feel better, and how did that work in your mind?
Yeah, so I think that's a very a legit question, because a lot of our patients certainly felt better, and we as clinicians get excited when they come back and subjectively say, I feel better, and everyone high-fiving and saying, what a great job we've done. My question has always been, what do we do with patients who don't say, I felt better, or feel like, hey, I may not feel better? And that is a lot of time validation for the whole clinical team when their peak VO2 actually starts going up. And again, we are working on this border of peak VO2s, right? 12.2 is someone who I would, in other, situation would be most of the time working on for transplant or advanced therapies. And then if I have the same patients who in the same condition, I'm not sure if I feel better, but my peak VO2 is up to 14 now. I think I'm definitely buying a time for that patient. That's how I clinically take it.
That makes sense. You had looked like you had one super responder, or you had lots of responders, but there was one that just really, any characteristics of that patient that was interesting?
Yeah, it's very interesting. It's very advanced patient with ischemic cardiomyopathy, with low AF, and the rest of the by CRT and CRT non-responder. So and then there were quite a few symptom super responders who I would call a symptom super responder, but by peak VO2 just a tracking 1.7 to 2 points improvement, which I wouldn't call necessarily a super responder by peak VO2. So I think we still yet to understand and phenotype better those super responders, what exactly triggered the super response, because I thought I knew what super responder was up until I created the data set for their peak VO2s.
Makes sense. Makes sense. That's awesome work. Thank you for that presentation. Let's move to Patrick and have Dr. McCann share data that he presented at the THT meeting.
Sure, happy to do that. In this transition, what we noticed obviously was significant clinical improvement, and what we started looking for was are there other impacts that the therapy is having on our patients? So I'll go through some of that data here, and just to give you an idea, we're all heart failure cardiologists with large programs. We function more as a community hospital in terms of our heart failure approach, although we do implant VADs as well. So this gives you a little bit of an idea of our background. And when we started looking at Barostim, we noticed the same response that Dr. Uranog was speaking of. We certainly had some super responders, and we were interested in what other response patients were having. So we did an ICD interrogation with our patients, and we started looking at non-sustained VTAC on this next slide here. When we were looking at this, obviously just retrospective reviews of the ICD interrogations at 1 year pre and post implant, but what we noticed was a little over 50% reduction in the number of events that people were having. And mind you, this was in patients that are on pretty minimal GDMT because they weren't able to tolerate it. That's certainly one of the approaches that we have changed in our clinical response to patients that are not tolerating GDMT is to consider Barostim activation therapy sooner. And with this, we're seeing outstanding responses. And this was just in the patients looking at NSVT. And so we took it a step further to look at the atrial fibrillation burden. As we know, in heart failure, atrial fibrillation burden is high, anywhere between 40 to 50% on reports. And we had about 28 patients with AFib, and we saw a substantial reduction 1 year pre and post in atrial fibrillation. And these patients did not, they're pretty equal in terms of antiarrhythmic therapy, and there were no additional procedures as far as ablations. So really, this is stemming from the fact that people are having significant neuromodulation in addition to their ongoing GDMT. After we looked at arrhythmias, we started looking at volume. What we've noticed when we've been implanting patients, we've been doing this for a little over 3 years now, is that they have a substantial effect in terms of natriuresis. And we've had to reduce diuretics. And so this was a case study looking at a patient. And you can see his blood volume analysis. He was about 23% or so excess in terms of his plasma volume. That dropped to roughly a little over 6%. But the big difference here is that that gentleman was taking Lasix daily at his baseline. We did not titrate GDMT as we were adjusting his Barostim, which we do for our patients. But 1 month post-implant, he was taking Lasix 40 once a week and had a significant reduction in his volume status with the same GDMT. And so we're seeing outstanding effects from the therapy. And so we looked over patients out to 12 months, and what we see is a consistent decrease in the amount of diuretics. And I think to Dr. Yarnoff and what he was doing with his evaluation, I'd be interested to see what that data looks like at 12 months, because I think that's really where we're seeing a substantial impact from the therapy, not only from after titration, but continued effect, certainly out to 12 months from what we've been seeing here and what we know from the data lasting out to 2 years, and then for some of our patients, even 3 years now with their therapy. And then lastly, we looked at our hospitalizations. And Dr. Abraham's going to focus a little bit more on this in the next section, but we don't really see a lot of our patients back in the hospital, and this is why we see a substantial reduction in hospitalizations with this therapy. And again, these are people on minimal GDMT because they just can't tolerate it, in terms of titration. And sometimes we've been able to add back some of that GDMT or up titrate after they've been completely titrated on their baroreceptor activation therapy, but substantial reduction in hospitalizations for our patient population.
Great work. Thank you, Patrick. And I think that there's a growing evidence that restoring parasympathetic control in patients with heart failure and reducing sympathetic activation not only has an effect on the heart, but also on the kidney stimulation from the sympathetic nervous system with renin-angiotensin activation and volume retention and all that process. So it's really, really great observations. And it also makes me happy to see the reduction in arrhythmias with the vagal restoration. So Dimitri, when we talk about exercise capacity, we also talk about how the autonomic nervous system controls heart rate during exercise. What are your thoughts about what Patrick just showed us in terms of arrhythmia reduction, atrial fibrillation reduction, and the reduction in the need for loop diuretics? How do you put that together with what you just presented?
Yeah, certainly one thing is I definitely am tracking and would like to continue to track the longer term CPX results for those, especially who will be now on a yearly CPX is tracking them. But I think the key point here is I'm more and more excited about PAT data, mainly because of this notion of parasympathetic tone during exercise. And I think that, there's another illustration of it's not just that you need to get rid of sympathetic tone. You need to restore the parasympathetic tone to get all of this back in check. And just one limb is not enough for it. And to also just to underscore, we also did see some anecdotal evidence for arrhythmia. Pat, question to you based on that data. Have you seen a little lag between the Barostim implant to the decrease of arrhythmia? Because what we are tracking is that it takes time to see the effect. And I've implanted several patients with VT and bad heart failure. They continue to have VT for first maybe 60 to 90 days and then become quiet.
That's exactly what we've been noticing in general with the effects that we're seeing. People feel much better generally by their second or third titration. We do about a 2-month time for titration, but we're seeing the effects in terms of volume and arrhythmias improving out past 6 months, and they continue to. And I think that goes along with actual, the modulation effect and the remodeling that we're seeing potentially with this therapy.
Yeah. Just also get back to quickly to that. The reason why we elected, our peak VO2 repeat at 3-month post titration is mainly so because you see the average peak VO2 was 12.2. So we didn't really know which way those patients are going to go in 3 months, and we didn't want to delay the necessary care if they needed to get to advanced therapies. That's where this early testing came from.
Jacob, what are your thoughts about putting all this stuff together thus far?
Well, I was gratified to see that all of these mechanistic steps and the interval surrogate outcomes culminated ultimately in a reduction in hospitalizations. I'm going to show you more data about that, but those were certainly consistent with the evidence that we were able to see, and I will show you in the next presentation. I did have a question for Pat. Was that reduction in hospitalization of 50%, was that all cause, or was that heart failure specific, or was that
Yeah, those were heart failure specific.
That's great.
Yeah, well, this is pretty amazing. We're kind of painting a picture of modifying the underlying pathophysiology in multiple different ways that I think will culminate here in a minute with the clinical outcomes of stability, of what we would consider stability. Kathy, are there any questions from the audience that we can entertain?
We do have one question, Dr. Adamson, from Dr. Filiberti in Tampa. Did you see a difference between ischemic and non-ischemic patients, and was there a correspondence in the peak VO2 and improvements in left ventricular ejection fraction?
Dimitri?
So I did not track the echoes 3 months after, so I have echoes later in the time, but we did not track that. And then that's why I can't comment on that. That's certainly a limitation there. I don't have echo data for that data set just yet.
Any difference in responsiveness between ischemic and non-ischemic?
Yeah, also can't comment much. I can tell you that when you break it, it's about 50-50, and I think 60-40 in this data set. Then nothing becomes significant right away. So it's a small sample.
Wonderful. Patrick, thank you very much for your presentation. It was a great work, and I really appreciate you sharing that with us. Let's move on now to Professor Abraham, and let's talk about healthcare utilization in people who receive Barostim.
Thank you. We'll take the next slide, please. I want to first acknowledge the contribution of my co-authors, 2 of whom are on this webinar with us tonight. So thank you for your help with this work. So the context is that thus far, the effect of baroactivation therapy on hospitalization has not been well defined. 2 prior studies, one a subset of the randomized Hope for Heart Failure trial, showed in 57 patients a significant reduction in events per patient year, specifically on the endpoint of heart failure hospitalizations. And a smaller study, single center experience from USC Keck, showed at 12 months a reduction in 12-month all-cause hospitalization. But these numbers are small and relatively limited. And so we wanted to take a more in-depth look at the impact of baroactivation therapy on hospitalization specifically. We therefore utilized the Premier Healthcare ChargeMaster database, which is a comprehensive national data set that involves over 1,300 facilities in the United States and captures data on 307 million unique patients, both in the ambulatory setting and the inpatient setting. And this is, importantly, an all-payer data set. We assessed events between January 1st of 2016 and June of 2023, and we compared event rates between the 12 months prior to implant and the entire interval following barostim activation until death or June 30th, 2023. And in this particular analysis, we defined hospital visits as inclusive of inpatient hospitalization as well as utilization of the emergency department. And we analyzed all-cause and cardiovascular events as defined by the Heart Failure Academic Research Consortium and used DRG and ICD-10 codes to define heart failure events. Next slide. The preliminary results are shown here. Between those dates shown, there were 306 patients who were implanted with baroactivation therapy. The mean age was 66 plus or minus 12 years. About a quarter of patients were female and about 1 in 5 were African American. The follow-up periods were 306 and 586 patient years, respectively, comparing pre-implant to post-implant. And these are the main results. As you can see, there was a dramatic 86% rate reduction in all-cause hospital visits following baroactivation therapy, and 84% reduction in cardiovascular-related hospital visits, and an 85% reduction in hospital visits due to heart failure. So pretty dramatic. So when we put this together with the earlier observations, we began to see now validation but a consistent reduction in hospitalizations across these 3 very different data sets that looked at different types of hospitalizations over different time intervals, and importantly in different eras, but there's a consistency in the signal that suggests the validity of these observations. Next slide. There are obviously some important limitations to acknowledge. There's no control group, so we cannot prove causation in this context, and we do not have adequate data to define the underlying severity of heart failure in the study population. Additionally, there may have been changes in disease management over time, including the fact that these patients may have been referred to advanced heart failure centers, such as those in South Carolina or Tennessee, where they would have been under the care of excellent heart failure doctors. So they may have had benefit that was external to the device implantation. Additionally, there may have been impacts of the COVID pandemic on healthcare utilization, but very importantly, more than 90% of the implants and the follow-up occurred after the COVID-19 pandemic had ended. So in conclusion, in this analysis of a contemporary all-payer database, we found that implantation of baroactivation therapy was associated with significant reductions in all-cause cardiovascular and heart failure hospital visits. And these findings were published in the Journal of Cardiac Failure and are available in open access format. And I had the privilege of discussing these findings with Dr. Adamson on the Brain Heart Continuum podcast, a link to which is shown on this slide. Thank you.
Great work. Thank you, Jacob. That's really amazing results. You know, I'm intrigued by the all-cause cardiovascular and heart failure hospitalization reductions. And given the limitations of this type of analysis, you really can't, you know, find a point estimate of effectiveness that can be generalized, but certainly the consistency across data sets is really important. But many times heart failure hospitalizations are counted without counting all-cause hospitalizations. So there's no way to know if we just simply shifted hospitalizations to a different diagnostic code. What are your thoughts about this all-cause and cardiovascular and heart failure hospitalization reductions? Pretty amazing across the board.
It is amazing, and to your point, it emphasizes that we did not just shift patients from one diagnosis category to another. And I think that perhaps speaks to the interplay of heart failure with other disease states. I mean, we certainly see in clinical practice, patients who have worsening heart failure can have exacerbations, say, of COPD and vice versa. And perhaps what we're seeing is an overall generalized improvement in these patients, that as their heart failure becomes better controlled, you see a reduction in their need for diuretics. They're less congested, they have fewer arrhythmias, they have better exercise tolerance. It may lead to an improvement in general health that impacts all organ systems and all comorbidities. Again, this is all conjecture, but I think the consistency across data sets and the reduction in all categories of hospitalization certainly becomes compelling evidence to support that hypothesis.
Dimitri, what are your thoughts about the reduction in hospitalizations? Very consistent across the line, very consistent with Patrick's data. Have you experienced that in Memphis as well? It's similar types of reductions in hospitalizations?
Yeah, I think that it's just it's impressive that the data exists now, because we all have this anecdotal single center data, and trying to the worry is always, are you going to be able to reproduce this in a large data set? And here you are reproducing it in a large data set. Number one, and number two is we have a large hospital initiative for heart failure readmission reduction. We just report our numbers for last year's, and it's drastic reduction, which correlates with a spike in heart failure devices and its utilization in the whole system. And I'm just applaud everyone who was part of it, just to put this a very important piece of data out there.
Patrick, you saw this at your center as well, so it's no surprise that you would see this, I guess, in this more generalized group. Have you seen this phenomenon as well of reduction in all-cause hospitalizations as well?
Yes, we have. I think our numbers probably would have looked just as good as what Dr. Abraham had presented, but early on we had such great super responders. We certainly tried this therapy in some very marginal patients that were not candidates for advanced therapies. So I think now that we've sort of dialed in our patient population a little bit better, we've certainly seen that. It's rare for us to see somebody that gets a Barostim back in the hospital. We do a quick titration, and we don't see them in the clinic very often after their titration either. They just do so much better. They're enjoying life, and it's a great thing to see. And what I've been really happy about is when you're doing it and everyone else is sort of saying, yeah, maybe we'll try this. Seeing this data has really validated what we've been doing the last few years. And it re-energized our group after THT, and I was sharing this with them, how good this therapy really is.
Well, let's talk a little bit about mechanisms. And Jacob, we've actually seen now, as we've said multiple times, we've seen sort of a progression of exercise improvement, which is a fundamental improvement in overall status, heart failure status, of course, and correlates directly to quality of life improvement. And we've seen a reduction in the need for diuretics. So volume control seems to be easier over time. I was struck by the case that Patrick presented, 40 milligrams of furosemide a day. I think it was transitioning 40 milligrams a week is what I remember you seeing in that case. And then, we see that then is associated directly with the reduction in hospitalization. Let's talk, what do you think is happening to make this kind of stability happen in our patients who receive this therapy?
I mean, I think the impact of sympathetic activation and nerve trafficking on the kidney is probably one of the key components. I think that's difficult to study, but certainly the data that Pat presented, the reduction in heart failure hospitalization, certainly speaks to the benefits on volume control, as you put it. Certainly seems to be a decongesting effect of the therapy. I'm curious, Pat, whether you've seen that in other patients, if that's been a generalizable experience with the reduction in diuretics, and perhaps that does then allow us to employ neurohormonal blockade more aggressively in some of these patients. But I do think the kidney probably plays a key role in this, and perhaps the changes that occur in the splanchnic bed in general, in terms of having less venous congestion as a result of changes in sympathetic tone and increases in parasympathetic trafficking, probably play a role as well.
Dimitri, what are your thoughts? Mechanism of action.
Yeah, I think that certainly we have to study splenic circulation, because I think that, all we see with the reduction in QO2s and hemodynamic responses to baroreflex activation therapy, it's still hard to explain why we see those changes, especially, something we didn't talk about today is the hemodynamic response, but there's a lot more we need to understand. One thing that, just to further try to understand the data that Pat presented, and we talked about this during THT, is looking more in that data sample and looking at the CKD stages and see how at different stages different patients respond to it. What we, and again, anecdotally in single center experience, see is that patients who have more of advanced kidney disease don't respond as well. It's hard to, they probably benefit the least in my experience. And those with, kidneys that are less advanced usually can come off completely diuretics, produce significant natriuresis. And then the, third one is that everyone wants to produce the data set and look at the, what happens with guideline-directed medical therapy post BAT a month into it. Once you normalize that process, whether by removing the sympathetic, adding parasympathetic, somehow redistributing volume. I'm very grateful for Pat doing this BVA on this patient. The only problem and downside of this is we just don't know what happened to total body volume. And that's what puzzles me all the time.
Yeah, and I think, certainly the autonomic effects are clear. I mean, the data supporting the use of this device clearly demonstrate a reduction in peripheral sympathetic nerve activity, an improvement of central parasympathetic control. And how that translates to exercise improvement, I think, is really speculation, but I think it's really interesting in that, when we exercise, if we don't have heart failure, we actually have an initial vagal withdrawal that is responsible for the chronotropic response to exercise. Patients with heart failure don't have that. Do you think that's playing a role in improving the exercise tolerance time that you saw, Dimitri, in your study?
Absolutely. I think it's, parasympathetic, you need parasympathetic to be able to exercise and to mount that response to heart rate variability, everything. Even when we go back into preclinical studies looking at this, I think that's, that's probably the reason why, this kind of like two-limb response of this therapy, which is different from a single limb response in the vagal nerve stimulation itself. And I think that's the key to success, affecting the two limb at the same time.
That makes sense. Patrick, you kind of taught me that we really ought to be looking at during follow-up and during titration. We'll talk about that in a minute, but I think you look at the diuretic needs fairly early, if not before implant. Tell me about how you do that, because I think if we're having much more of an effect with the same dose of diuretics, or even much less of a dose with the diuretics, what are the risks of maybe continuing inappropriately?
Sure. I think it's difficult to pinpoint who's going to be the super responders, and those people certainly have a dramatic reduction in diuretics. I can remember one of our first patients. She used to take 80 Lasix twice a day, and she takes it maybe once every 2 or 3 weeks now, and has outstanding volume status compared to what she was previously. We had the benefit early on of keeping our patients overnight as a caution with our surgeon when he was getting used to the technique. And we would get responses from the patients, telling us to please stop their diuretics because, they're having so much urine output after the implant, and we had not made any changes to their diuretics. And so as we continued to see that, we actually started cutting back on the diuretic dose after implant. And so we usually will cut back by about 50% after implant now. And if we need to adjust when they come back in for their clinic follow-up, we do. But there's quite a few times where that stays reduced, if not reducing even further for patients. I think that's going to be the part as we move forward with this therapy, is trying to understand the degree of response, right? Which patients are going to have that ability to go from an NYHA class 3 to 1. And we have quite a few patients like that, and have yet to find the exact reason why by looking at a lot of data, but certainly the clinical response is there, and those patients just don't need as much diuretics.
I think that's good advice to at least, not fire and forget the diuretics. You can fire and forget this device, after titration, but don't fire and forget the diuretics. You really need to reevaluate the need for that, and possibly up titration of neurohormonal antagonists.
Correct, because that's the other part. Sometimes I think people, if they come back in with a little bit of softer blood pressures or hypotension, that they want to think that it's to the device, and it very well just may be that the person is over-diuresed at that point.
Makes sense. Hey, Kathy, do we have any questions from the audience? And I really encourage you to make this interactive. We're gonna have this discussion, but we'd love to have your input.
We do, Dr. Adamson. We have a great question from Dr. Jan Mohammed. Any thoughts or experience on a study potentially implanting Barostim during an index hospitalization and seeing if that would lead to a reduction of subsequent heart failure events?
That's a good question. I think that study has yet to be done. How many of you implant Barostim during a hospitalization for an exacerbation of heart failure?
Yep.
Patrick, do you tell me about that?
Yeah. So when you say index, I wouldn't do it right off the bat without GDMT, certainly, right? But if somebody has been we've attempted GDMT and they're either not tolerating it, or we can't get them up to maximal doses and they're still having significant symptoms, and they come back with a hospitalization. If they meet criteria and we think they're going to be a good candidate, we usually will go with it on the inpatient side of things, because to me, this is an extension of GDMT when people can't tolerate it, and we know it's going to have improvements. We've had plenty of experience, and a lot of other folks are having similar experience to what we're seeing. And so we will move forward on the inpatient side if we can get it accomplished. And usually that's more a matter of, just checking with insurance. But I think it benefits the patients, and then we will do a rapid titration, over the next 2 months in the outpatient realm. Most of the time, when we look at it, a lot of people, when we've looked at previous therapies between outpatient and inpatient medications, the majority of the time after we diurese somebody and get them, approaching euvolemia, they're kind of back to baseline already, right? And so I don't think there's any need to delay the care if you've tried all the other, options in terms of medical therapy.
Makes sense.
Waiting for somebody to prove that they're sick, to me, is doing that person a disservice, right? They're not enjoying life. Their quality of life is terrible, and we have an option that can help them.
Makes sense. Jacob?
The discussion about hospitalization, it's a little bit of a pivot, but we didn't discuss it in the slides that I showed from THT, but in the paper, we also showed that there was a significant reduction in length of stay for any subsequent hospitalization. And that was true, again, across the board, whether all-cause cardiovascular or heart failure-related hospitalizations, the length of stay associated with those admissions also went down. So the talk about hospitalization just reminded me of that important point. And, clearly, any payers in the audience, that should get their attention, because that's, one of the few things that at least we now have data to show actually improves length of stay in addition to reducing overall hospitalizations.
Makes sense. Yeah. And it is, certainly possible to implant while the patient is hospitalized and stabilized in a hospitalization. And so that is certainly an option with many payers. So let me ask you this: how do you titrate? So the idea here is we implant this electrical stimulating device on a nerve plexus to stimulate the baroreceptor nerve, which we do. All the things that happen with an implantable device, albeit this is not inside the blood vessel, it's on the epivascular area. But there is scar tissue, there's impedance changes, there's changes that occur over time, so that the therapy is up titrated to a target dose, is what we did in the clinical trial, similar to what we did with say beta blockers in those clinical trials. So how do you up titrate? What's your scheme, and how do you see this up titration period happening? Let's go with Dimitri first.
Yeah, I think that we have evolved since VHF, and our titration is a lot faster. One thing that we had to learn ourselves, we didn't talk to Pat McCann back in time, but our first few patients did have AKI, and they had AKI because they just over-diuresed and we didn't adjust their diuretics. So with every titration, we reassess the diuretic needs for those patients. And I just have to underscore, I get calls about it all the time when providers ask me, hey, that patient was up titrated, is coming back hypotensive. I don't know what to do. I'm not going to decrease Entresto. And the usual miss is over-diuresis in those patients. Those patients tend to be hypotensive because they're just volume depleted. Then withdrawn diuretic or decreasing dose diuretic every titration episode. 90% of our patients will be titrated over a 6-week period at most. And then there is a group of patients who would have, hypotension and be more sensitive to it. But again, those are patients that are going to go on a slow titration route. And one more thing is the stim, like the electrical stimulation or capture of the muscle around the electrode. And that's where, again, 90% of my patients would be okay and tolerate this up titration well in 6 weeks. Some patients, especially smaller ladies that don't have too much of the tissue in the neck, they will be the ones who will titrate slower because they will still have a stim. They'll have hoarseness in their voices, and then they'll have problem. But as soon as that electrode fibrosis over it, then you should have no problem titrating and maxing them out. That's kind of our approach.
How about you, Patrick?
Yeah, we titrate over an 8-week period. Generally, we tried. We started out doing it on a monthly basis. I think that's far too long. We changed that at the behest of a patient who reminded me he wasn't getting any younger, and it worked beautifully. And with that, we took off and we did it every 2 weeks. Now, we have tried a few patients on a weekly basis. We set ours up on for Titration Tuesdays for our device program. And we tried on a weekly basis, but it's difficult, I think, sometimes for patients to come back in, but also to what Dr. Yarnoff was saying, sometimes, especially in your petite ladies, they'll feel a little stim while they're still healing from the procedure. And so we've just taken the approach to do it every 2 weeks. Usually, like I mentioned earlier, we see patients noticing benefit, more benefit after the second and third titration. Occasionally, when we're going up on that fourth titration, the person finally gets really good benefit, but usually it's before then. And we usually leave them somewhere a target range of about 7 to 8 milliamps.
Okay.
Now, what do you do if you can't get up to 8? Do you ever play with the pulse width? We do.
We'll change the pulse width, and we look at the pulse width and the amount of milliamps to how that would correlate depending on the pulse width. And so we've made that change for patients, and that's helped certainly.
Jacob, at your center, how have you evolved your titration process?
We probably look a little bit more like Pat's program. Many of our patients have actually come from great distances from rural Oregon or Washington. So the feasibility of doing the rapid titration has been a bit more challenging. So I would say our titration is more over the 8-week schedule than the rapid titration. But I'm taking it because I really like that idea of trying to titrate more rapidly. So if we have more local patients, we'll try to give that a trial.
Kathy, I think we have Professor Miller who has a question, I think, has popped up in our welcome, Professor Miller.
Yes. So Professor Miller's question is, coming back to patient selection, has the panel found a correlation with NT-proBNP level or EF or a cut point for either level that helps anticipate response and select patients for the therapy? And this wasn't part of Professor Miller's question, but perhaps additional patient selection, is there are there triggers that you look for? Are there triggers that your patients might say that make you think this patient might be a good candidate and could benefit from Barostim?
Dimitri, what are your thoughts?
May sound very controversial, but for EF less than 35% and with NT-proBNP that is within the range, for us, you just need to have heart failure syndrome and symptoms. For what we've noticed is that for device like Barostim, where you're not treating, you don't need a myocardium, unlike in the devices that have to capture myocardium like CRT or CCM. With this device, you really treat the body response to the heart insult rather than the heart itself. And for us, it's truly, we've seen a response across the whole spectrum of ejection fraction, under 35%. And I think that the true where we get in trouble, where we push an envelope too far, is in those advanced vasodilated patients that are just becoming more vasoplegic and hypertensive, those that need to cross into transplant VADs. Otherwise, that's kind of like my statement on that.
I think from a functional status, I mentioned earlier, we changed our approach to dial in a little bit more, and we're really probably focused on NYHA 2B that have had a recent 3D compensation or your 3A folks. I think when you're starting to get to your 3B class 4 folks, to Dr. Aronoff's point, they're probably just a little bit far gone and they need advanced therapies. Now, we certainly have had some 3Bs that have had really good response to inotropes, those patients that suddenly become hypertensive with inotropes, and you get it back on GDMT when they started dwindling after coming off inotropes, 4 to 6 months later. We went ahead with Barostim, and they've had great responses since. But for us, that's kind of the sweet spot. And then to the NT-proBNP, we don't limit ourselves necessarily. The recommendation obviously is 1600. We've certainly have patients that have been higher that have had great responses to therapy. And so I think it's a guidance, certainly, but as you start to implement the device in your program, you'll start to find more patients that can get benefit from therapy. But the part in terms of picking your patients, one of the things we've changed, we were talking about this, Dr. Fadim and I, we titrate aggressively with GDMT. We try to do the strong HF, getting it in 4 to 6 weeks if we can, but every program's a little different. But I would say if you've been doing all that and you're 3 to 6 months in and the patient's not going anywhere and they're on minimal therapies, then really we should be considering device therapies.
Yeah, I think practically speaking, as an advanced heart failure program like these gentlemen here, we're seeing, a wide range of risk. And we certainly, if we have a patient where we're concerned about whether they're too advanced, we will undergo right heart cath, we'll do cardiopulmonary exercise testing. And frankly, some of the consideration is, are they eligible for a VAD or transplant? If they're not, for whatever reason, then we'll probably be more likely to consider device therapy. If they are, we will consider using this. And I think it's an important point that implementation of baroactivation therapy doesn't preclude one from going on to get transplant or LVAD or other therapies. That's an important point. So we'll certainly tailor the decision, but I think as our initial decision point, we're looking at, does this patient meet criteria from CPET or hemodynamic assessment to really be a candidate for VAD or transplant?
I would caution with that, to make sure, in those patients that, Dr. Abraham was talking about there, as far as not maybe getting VAD or transplant and getting that, just to manage expectations, right? Because what we've seen in some of that patient population that are on the border is, although they do well, we have not had the thriving or super responders that we've had in the earlier class 3s.
Yeah, and it turns out in the BEAT-HF study, there were early on a few patients that had NT-proBNPs above 5,000. They looked to me to be sort of stuck there. You couldn't transition them from a decompensation and volume control into a lower level of NT-proBNP. And those patients actually had about a 65% 2-year mortality, and they almost acted like a rematch population, the control population rematch. They were clearly advanced heart failure patients. So the purpose of FDA approval based on 1600 NT-proBNP or lower is that was the population in which the BNP did go down significantly. And that was the third component of the expedited approval pathway approval process. And certainly that's the population, EF less than 35, NT-pro less than 16, class 2 or 3 symptoms with a previous hospitalization or the NT-pro qualification. That population seems to be the sweet spot where we see the biggest effectiveness. We have another question, I think, Kathy.
Yes, Dr. Adamson, we've just got just a few minutes left, but we did want a follow-up question to pin down some of your comments about overdiuresis. So do you see any need to reduce or alter the GDMT after implant, as one might expect lower BP with a shift in that neural tone?
We've actually seen a stabilization of blood pressures. If anything, we will see an improvement in blood pressure. So this is the part after we've titrated the device and diuretics that we come back to course correction and adjusting GDMT if they can tolerate it better now. And we certainly have seen that in a number of patients where their hemodynamics are better, they're able to do more, and they're able to tolerate additional GDMT. So we've actually titrated after the device, obviously to get the benefits that we're all well aware of for GDMT.
I would just underscore this again. If you see hypotension post-device implant, ask yourself what their volume status is, because most likely their volume status is down. But this is, we see the same exact thing what Patrick sees. As you chronically stimulate barrier reflex, with the time, just like in this question, neural tone rebalances, and you actually see a rebound of pressures, and most of us see actually increase in guideline-directed medical therapy uptake or dosages of it as the time goes. But just ask yourself first, why does blood pressure is low? And the our usual instincts to go down on GDMT or go down on the output from the device are wrong ones. Most of the time, it's the diuretic adjustment that needs to happen. And again, in very few rare cases where we do BVA, and it actually just needs a slow titration. But most of the time, it's not a GDMT.
Well, why don't we take the next 2 minutes, and we'll start with you, Patrick, and just kind of summarize what you observed and what you've learned from putting together all this data that was presented at THT and presented this evening.
Yeah, I mean, I think, what we've learned is we're consistently providing better benefit to patients that were continuing to suffer from heart failure symptoms, and that we need to implement device therapy sooner rather than later. And we should be equally aggressive with device therapy, just as we are with GDMT in patients that are intolerant to medical therapy.
Dimitri?
So I think that just in general, we have done a great job in heart failure, but it continues to be deadly disease. And we've done phenomenal work by implementing GDMT that can extend the suffer. And quality of life is very important. And those patients continue to come back to clinics asking for help. And there are two options. We either give them the help, or we'll just pat them on the shoulder and make sure they get used to those limitations for years. So and that's how we practice nowadays.
Awesome. Thank you. Jacob?
I would just conclude by saying, we really now are turning our focus back to patient-centered outcomes. Being able to walk farther, staying out of the hospital, doing better at home is really critical. And while we as cardiologists like to think about hard endpoints like mortality, I think these endpoints really matter to our patients. And this is a therapy that is complementary to GDMT that allows our patients to realize those benefits.
Awesome. Thank you, panel members, for joining us this evening, presenting your data, and thank you ladies and gentlemen, for joining us for this webinar. On behalf of CBRX, I wish you a great evening, and certainly look forward to any further questions you may have to ask us. Send those forward, and we'll respond. So again, thank you for joining us, and have a great evening.